If you are a surgical tech student or you're new to the operating room and draping still feels like a mystery to you, this video is going to change that. We'll be discussing patient drapes and equipment drapes to avoid embarrassing situations and the knowledge that separates CSTs who look like they belong in the OR from the ones who look lost when you're standing across the table from a surgeon who expects you to know what you're doing. My name is Derek. I'm a surgical technologist with over 11 years of real operating room experience as a traveling tech, an orthopedic specialist, and the founder of the Surgical Guru Academy. And I built this platform for one reason, to give surgical tech students and new grads the real education that school never gave them. Now, before we get into it, I gotta give a quick shout out to my boy Anthony. Anthony just joined the Surgical Guru Academy last week, and one of the first things he told me was that he needed help with draping, bed setups, and positioning in the OR. And that's exactly how we operate inside the academy. When you join and tell me what you're struggling with, I will prioritize it. I'll create content on that subject and go deep into it. I build the content around what you actually need. So Anthony, this one's for you, brother, and for everyone else watching who's in the same boat. Let's get to work. All right, so let's begin this presentation, this PowerPoint presented to you by the Surgical Guru Academy. Surgical Drapes in the Operating Room 101, everything every surgical technologist must know about surgical drapes before scrubbing their first case. All right, so why so many students struggle with draping? First, I want you to know that you are not alone. Everybody has experienced this. I know for sure I went through these exact same feelings and experiences when I first got out of school 11 years ago. First things first, information overload, all right? There are dozens of different drapes. There's so many different drapes. Many of them look identical. They look the same. So it's very easy to understand why you might feel like it's challenging, like it is a difficulty, and it's because there's a lot of information. So, once you break it down piece by piece, it will definitely get a lot easier. You just got to trust the process. Hospital variation. Every facility stocks different brands and products. So depending on the hospital that you go at, if you're going to one hospital or many hospitals, there's going to be a variation of different brands. It's like Coke and Pepsi, right? And sometimes they're a lot different depending on the brand that you get. Surgeons' preferences. Every surgeon may insist on a specific setup or sequence. So you might have the same procedure, like a total knee replacement, and the doctors could have a completely different way of draping this procedure. There's definitely different ways to skin a cat. So everybody has their preferences and a different method, and sometimes you might have 2 or 3 doctors who do the same procedure at a hospital, but each of them want it draped in a different way. So that could tend to be a challenge, especially early on remembering. And sometimes you're like, oh, wait, Dr. such and such likes to use this. And it may confuse you, and you may give them the wrong drapes because of that. So that's one thing to keep in mind. And then fear of contamination. One wrong move and the whole field is compromised. Yes, you do not want to contaminate. You don't want the doctors looking at you like you are inadequate or as if you don't know what you're doing. So sometimes that can be a struggle when it comes to draping as well. And also fear of judgment, which also goes hand in hand with the fear of contamination. You're in fear of contaminating because you don't want to be judged. You don't want someone yelling at you. I mean, there's been times where I'm draping with a doctor, and there was this one doctor, he was crazy about draping at one of the hospitals I worked at. And he used to rip off all the drapes. If he felt like anything was contaminated, half the time people would be looking around like, wait, what got contaminated? Like, I'm not sure what happened. He would just rip everything down. And sometimes it's like that, and the fear of judgment. Nobody wants to be yelled at by a surgeon or preceptor. So I can understand why students struggle with draping, but just remember, you are not alone. All right, so what is surgical draping? Draping is a patient safety system. So what draping does is it creates a sterile field. It separates the surgical field from the non-sterile areas of the environment. So the things that we open up sterilely, such as the surgical drapes and everything that's on the sterile field, it is rendered sterile. And when you create that sterile field around the area where you're going to do surgery on the patient, you have a sterile environment so that the area in which you are operating on can stay as sterile or surgically clean as possible to prevent any type of infection, right? That's the second point in this slide, is it reduces contamination risk. So barriers between the patient's skin, the environment, and surgical instruments. The next one is isolate the surgical site. So it limits exposure to only the area being operated on, nothing more. Everything else is covered. That way we can make sure that that area stays as clean as possible, and it protects the patient. It prevents SSIs, which are surgical site infections that can be life-threatening. So that is the purpose of draping and surgical draping. All right, the two main categories of surgical drapes. You have patient drapes, right, which cover the patient's bodies, which creates the sterile field around the surgical site. Is specialty specific. So the designs, you have laparotomy drapes, you have laparoscopic drapes. The difference between a laparotomy drape and a laparoscopic drape, sometimes the laparoscopic drapes have pouches in them. That way you can put the laparoscopic instruments in them, or you can put your cords in there, such as your camera cord, your light cord, different instrumentation that you're going to be using. That way you can prevent it from falling on the ground. You have orthopedic drapes, such as a total knee drape, which is a fenestrated drape. It has a hole right in the center of it. That way you can put it right over top of the knee. You have hip drapes, you have neuro drapes, you have all different types of specialty specific drapes for the particular type of surgery that you are going to be doing. Placed by the scrub tech and the surgeon. So this is why it is important to understand draping as a surgical tech, because a lot of times you are going to be responsible for helping the surgeon, helping the doctor put the drape onto the patient. And now you want to know what you're doing, because you don't want to contaminate yourself, like we talked about in the last slide. So it is very important to understand that. And then examples here, it puts laparotomy, hip, knee, craniotomy. So patient drapes versus equipment drapes. So equipment drapes cover surgical equipment and devices, such as a C-arm. We use C-arm fluoroscopy for x-rays intraoperatively. So during surgery, we use x-rays during a surgery, like a fracture, an ORIF, an open reduction internal fixation of, let's say, an ankle, right? We would use an x-ray. The x-ray would come in, but you can't have a non-sterile item going on top of our sterile field. We have created this barrier of sterility. So in order to be able to take x-rays intraoperatively, you need a C-arm drape to cover the C-arm. And devices, another example would be like, I do Mako total knees. So you have the Mako drape to render the Mako robot sterile, and then you also have the drape for microscopes if you're doing spine cases or ENT cases. And if you're doing a vascular case, another device that you might use would be a Doppler. So we have these Doppler probe covers that cover the Doppler. That way you can use it on the sterile field. So the whole goal of this is to maintain sterility of large machines or devices in the field. It says unique design for each type of equipment. So there's different drapes for different types of equipment, and they're all designed specifically for that piece of equipment. Often placed by scrub tech and circulator together. So some drapes you're able to do on your own. You're able to drape it by yourself, but other drapes you actually need help from your circulator, and they will grab the other end for you and help you put it on because of how large the drape might be. For example, whenever I drape the miniature C-arm, there's a small version of fluoroscopy. Sometimes I need help from my nurse, depending on the type of drape that we have. Some of them I can do by myself, but there's other ones where I'm like, hey, can you grab the end of that for me? It just makes things a lot easier. Or another example would be like the robotic arms on the Da Vinci robot. I can, and I typically put those on my own. However, it's so much easier when you have a nurse that will help you do that. So sometimes I just like my nurse helping me do that. So examples that we have on the slide are C-arm, robot, microscope, and light handles. Also, light handles help you move around the light when you are doing surgery. All right, so section 1, patient drape. So we are going to go through these, just a quick little rundown of the patient drapes that we use to cover the patients, specialty by specialty. So number 1 here, we have a laparotomy drape. This laparotomy drape here in this area is used for general surgery, for abdominal and colorectal procedures. So the laparotomy drape just has a middle right in the, it just has a hole, excuse me, right in the middle there, which we use for basically anything where we're going into the abdomen. So that could be an open cholecystectomy when we are going in there for the gallbladder, bowel surgery. We use that to go in for bowel surgery, appendectomy if you're taking out the appendix. I mean, a lot of these common procedures that we have here, we now do a lot of them laparoscopically, and if not laparoscopically, then we probably do them robotically. We've been getting away from a lot of open procedures. You don't see them as much. I mean, you still have doctors who do them. If you have a patient who is not a good candidate for laparoscopic or for the robot, or if it's a emergency, then maybe we will just go in regularly. But most of these we do laparoscopically now. But this is why you would use a laparotomy drape, is for this reason. And even for laparoscopic cases, sometimes, well, you would use a laparoscopic drape because the laparoscopic drape usually has the pockets in it. But common confusion is students confuse this with a split drape. Fenestration position varies by surgeon preference, and check the window size before draping. So exam tip is that laparotomy drapes have a pre-cut fenestration window over the abdomen. All right, the next drape is a GYN perineal drape. So depending on the type of GYN procedure that you are doing, there are actually different types of GYN drapes. There's legging drapes, which go over the patient's legs, which are resting in stirrups. And then sometimes you just put like a little small medium sheet up top if you're doing most of your work in the vaginal area. But if you are also going to be going into the abdomen, then you need, like an all-in-one drape, which covers the legs and then also like gives you everything you need up top as well. So this could be used for OB, GYN, urology. The common procedures are hysterectomies when you're taking out the uterus, DNC procedures, dilation and curettage, and perineal repair, and also vaginal delivery support. So common confusion: C-section uses a different drape. Do not swap them. Legging drape versus plain perineal drape. And by perineal drape, what they're saying is like a GYN drape. I suppose that's another name for it. I've never heard it referred to as that, but I don't know everything. Positioning is critical for this setup. So exam tip: GYN drapes have leg portions or pouches to accommodate lithotomy positioning. So right at the bottom of the drape, under the perineal area, is usually a pouch which can catch fluids, and sometimes the doctors like to store their instruments in there. So yeah. Next is extremity drape, upper extremity drape. This is used for hand surgery or orthopedic upper extremity cases. Common procedures would be carpal tunnel release, ORIF of the wrist, open reduction internal fixation or radius, trigger finger trigger finger release, tendon repair. So whenever you're doing work on the hands or the upper extremity, then that's when an upper extremity drape would be appropriate. Common confusion: students forget to cover the tourniquet area. So we want to make sure we cover the tourniquet area. Stockinette should be applied before draping. So typically we put the stockinette over the hand. Depending on the type of surgery that you're doing, determines, and also surgeon preference determines whether or not you're going to use a stockinette. Impervious drapes for required for wet cases. So yeah, most of the time we are using impervious drapes. All right, so next, this is the lower extremity drape, similar to the upper extremity, except it just applies to, legs, podiatry surgery, orthopedics, common procedures, bunionectomy, ankle, ORIF, open reduction, internal fixation, Achilles tendon repair, lower leg fracture fixation. So when we are working on the leg is when we will use the lower extremity drape. Common confusion, stockinette improperly applied before dressing. So you want to make sure you put the stockinette on correctly. A lot of times we will take a Coban and wrap up the stockinette. That way it won't fall off, because it's essentially like a sock and you need something to hold it on tightly. Tourniquet position must remain accessible. I don't know about all that. Don't contaminate the foot during elevation. So, okay, it's saying tourniquet position must remain accessible. So, I guess that's saying if you have a sterile tourniquet, sometimes people put on sterile tourniquets, but most of the time, your doctor will put on the tourniquet non-sterilely, and it will be underneath the drape. Don't contaminate the foot during elevation. An exam tip: lower extremity drapes wrap the foot and leg circumferentially. Check if stockinette use is required per your surgeon's preference, like I said a minute ago. All right, a hip drape. So we use hip drapes during orthopedic total joints, hip replacement, trauma, a total hip arthroplasty, posterior approach, total hip arthroplasty, and anterior approach, total hip arthroplasty, or a hip fracture repair, ORIF, which is an open reduction internal fixation. So common confusion, posterior versus anterior approach, different positioning. And depending on where you work, again, it may be a different drape. Perineal post must be accounted for in drape layout. All right, so I believe what they're referring to there, we call it a shit stick. And we have that on the fracture table when we are doing gamma nails. And if we are doing a gamma nail on a fracture table, we're most likely not using a hip drape. We're probably going to use a shower curtain. And the shower curtain is a different drape altogether that we use to just cover one side of the patient's body. So C-arm access needed, so don't block the imaging path. So with the shower curtain, the last time that I did it, the doctor actually let it lay down on the patient on the other side, and I needed to drape the C-arm as well. I've been places where they put the post up on the fracture table so high that the shower curtain actually goes over the post, and the C-arm, it can come in without contaminating the field because it stays on the other side of the curtain. So again, this always depends on the doctor's preferences and how they like to do things. Exam tip: hip drapes must allow intraoperative fluoroscopy access. Always confirm if the surgeon needs C-arm clearance before final drape placement. And again, on a total joint, for a total hip arthroplasty, most of the time we don't use a C-arm. So this is a little bit misleading, because a hip where you're doing a gamma nail, then yes, you will be using fluoroscopy. But for a total hip arthroplasty, you're not going to need a C-arm. So hopefully you guys are understanding, especially the newest students. I know that there's a lot of terms I'm throwing out, but anything that you have questions with, please leave it in the comments and I'll be happy to get to it. The next one is a total knee drape. So orthopedic total joint, total knee arthroplasty, revision total knee, unicompartmental knee replacement. Students forget to apply the stockinette before the drape. So, I mean, it says common confusion, but normally you're going to be doing this with a surgeon, and the surgeon will let you know exactly what they need, and you will be prepared. whoever your preceptor is should be letting you know the cadence or the sequence or steps that you're going to take in order to drape per the doctor's preferences. So by the time you are actually sitting there and draping with the doctor, you're not going to have to worry about that because they'll tell you like stockinette, Coban, extremity drape, especially knowing that you're a student. Tourniquet height must be verified before draping. So what that is trying to say is, yeah, you're going to verify what size tourniquet you're going to be using for the patient. And most of the time, you're going to have tourniquets inside the room ready to go before the doctor gets in there. And a lot of the times, your nurse is going to be the one that confirms which tourniquet the doctor is going to need. Knee holder or post must be accounted for. So, in order to be able to rest the leg up, a lot of times we use a post that they put into a bracket. The bracket attaches to the bed and the post goes inside of the bracket. So you're going to need that knee holder, absolutely. So next is the shoulder arthroscopy drape. You use this drape in orthopedic arthroscopy cases or sports medicine cases. The common procedures are rotator cuff repair, slap repair, shoulder stabilization, or bicep tendinosis. Common confusion, fluid management pouch often gets overlooked. So yeah, you're going to have that fluid management pouch, and a lot of times you're going to plug up your suction to it because during an arthroscopy, you're going to be running fluids into the shoulder. Or even in the arthroscopy, those drapes are going to have a pouch as well and going to be collecting fluids. And you need to plug that up to suction and throw that suction to your nurse. That way you can make sure that doesn't get all over the floor. Beach chair versus lateral decubitus, different setups, and fluid contamination bags must be positioned correctly so that you don't have saline spilling into your socks. You don't want wet socks. Shoulder arthroscopy drapes include a fluid collection pouch. Fluid management is critical to prevent pooling under the patient or wet socks. Next is the knee arthroscopy drape, which we were just referencing. Orthopedic arthroscopy, sports medicine, ACL reconstruction, meniscus repair, chondroplasty, or loose body removal. Fluid pouches must be opened and positioned before draping. Tourniquet application sequence is frequently missed. I don't know why I keep talking about tourniquets. Camera cord management planning before scrubbing. You want to make sure that your cord management is on point because there's a lot of different cords. You have the camera cord, you have your light cord, you have your shaver. In arthroscopy cases, you might have your burner, and you're going to have suction. Potentially, you're going to have your inflow tubing, which is giving you your fluids that are going into the knee. Sometimes they want outflow, so you need suction for outflow. And then sometimes you're going to need another suction for your shaver. And depending on what type of case they're doing and how long it's going to be, maybe not. Sometimes they need a third suction for your burner as well. Sometimes you could just switch between the two, but other times you might need an extra one. So all of those tubings, it could be a lot. And I have a video on the channel, a reel, a short, that shows me organizing my cords, but especially if you don't do it all the time, even experienced techs, like sometimes it can take a second to get all these cords off the field. I know some people who prepare it beforehand, who have beautiful mail stands and do it so well, but it can be a challenge for sure. And that was definitely a challenge for me when I first started my career. All right, next is a spinal drape, which gives you access to the spine. It's for neurosurgery and orthopedic spine. Common procedures are lumbar discectomy, spinal fusion, T-lift, P-lift, A-lift, cervical laminectomy, and vertebroplasty. Common confusion, spinal drapes are long, hard to unfold without breaking sterility, so you're going to need to be careful, or of course doing it with the surgeon, or even a PA or a resident, whatever help that you have. It's definitely important to take the help. I don't normally drape on my own. I know some people that do, and I know some doctors that actually prefer for their techs to do that, but I don't want to make any mistakes. So, imaging ports must remain accessible for intra-op X-ray, and prone positioning challenges draping approach significantly. Spinal drapes are amongst the longest patient drapes. Practice unfolding technique carefully. Length increases contamination risk. So you want to be careful. Craniotomy drapes is next. That's for neurosurgery, for brain tumor resection, AVM repair, aneurysm clipping, and decompressive craniectomy. Common confusion is head fixation. Mayfield pins must be accommodated. Microscope draping happens simultaneously. Plan ahead. And neuromonitoring leads must remain accessible. The next the exam tip is craniotomy drapes must accommodate the Mayfield skull clamp. The microscope will also need draping. Coordinate with your circulator. So microscope drapes are not easy to drape. I can understand why that would be a challenge for many people. All right. But we will post more videos showing how to drape the microscope. All right, next is bilateral extremity drape. This is for orthopedics or plastic reconstructive, bilateral hand procedures, the bilateral knee staging, or bilateral vein harvesting. I have used this myself whenever I've done bilateral total knees. A common confusion is students apply a unilateral drape. Yes, so I think a mistake here is grabbing the wrong drape, forgetting to grab a bilateral drape, having a unilateral drape, and then the doctor looking at you like, what is this? This is a bilateral case. 2 separate sterile fields may be required depending on, what exactly it is that you're doing, or the doctor, etc., etc. Confirm with surgeon before setup if you are doing a bilateral drape, or if they would like a bilateral drape. Bilateral drapes expose both extremities simultaneously. Confirm with the surgeon before setup. Some prefer 2 separate setups. All right, so next is an arm U drape. So sometimes when people are doing arms or extremities, rather than doing an extremity drape, they will take a U drape. So they'll take a U drape to go under the area that you're doing surgery. And then at the very top, they'll take a bar drape to help close off the sterile field. Specialties, ortho, general, vascular. Common procedures, arm positioning drape. Create sterile border at arm base and used in shoulder and upper extremity cases. Common confusion, U drape versus split drape. Students mix these up. Opening the U must face the surgical site. Works with towels and additional drapes. And exam tip. The U drape is placed around the base of the extremity. The opening of the U faces toward the surgical site. Impervious stockinette. So we've talked about this a bit. It is used in orthopedic and hand surgery. It is placed completely over the limb to isolate it. And a lot of times it's wrapped in a coband depending on what it is you're doing exactly. It's used when extremity is passed through the center. It is used for upper and lower extremity procedures. Common confusion. O-drape is slid over the hand first. Coordination required. Students contaminate the outer surface during application and ensure the surgical site remains visible through the opening. All right, exam tip. It creates a complete circular barrier around the extremity. The extremity is passed through the center hole while maintaining sterility. The O-drape. I've never heard it called an O-drape before. All right, and number 2, equipment drapes. So keeping machines sterile in the surgical field. So here we have the C-arm or the fluoroscopy drape. Orthopedic, trauma cases, vascular cases, spine cases. It's used in hip procedures, not usually a total hip unless the doctor needs it. Most of the time not. Knee imaging. Fracture fixation with live x-ray. vascular angiography, angiography, and spinal instrumentation. And it's also used during cystos when you are doing when you need fluoroscopy during cystos. Retrograde. Common confusion. Students don't secure the C drape before the C drape is brought in. So it's good to put rubber band around it. If you do not put a rubber band around it, which usually comes with the C-arm drape, then too much of the plastic can be sitting in the field and it can obstruct the surgeon's view of the surgical field. Drape must cover the entire arm, including the image intensifier, and never allow the circulator to touch the sterile portion. So exam tip, C-arm drapes must cover both the image intensifier and the x-ray tube. Coordinate with the surgeon. This is a team drape. Yeah, sometimes, somebody can help you grab the other end. But once you get more experience and it gets easier, then it won't require you really needing help. It's not that hard. If I can do it, you can do it. Surgical microscope drape. So yeah, this one is for neurosurgery, spines, ophthalmology, eyes, and ENT. So common procedures: brain tumor resection, cervical spine, microvascular reconstruction, and autologic surgery. So this is not the easiest drape to put together. I worked somewhere in North Jersey where we needed to put this on the microscope, this drape, and you had to make sure the drape we actually had wasn't the right size for the microscope. So we had to like kind of makeshift it, you know. There was two sets of eye holes, one for the doctor and one for the assistant, but there wasn't enough holes. So it was an interesting experience, but it definitely takes some practice, I would say, to get this down. I mean, everything kind of does, and depending on whatever you have the most exposure to is what you are going to be the most comfortable doing. It says microscope drape is large and awkward to apply alone. I like to do this with my nurse. That way they can help grab the end of it and like pull it for me. But it is very important also to understand how to do it yourself. Lens must align precisely. Imprecise placement will equal a case delay. And it must be applied before the scope is positioned over the field, obviously. You don't want a contamination. All right, the next one is the Da Vinci robotic surgery arms. This is used for robotic cases, general surgery, urology, GYN oncology, thoracic, everything that you're going to be using the robot for. Obviously, you're going to need to drape the arms. There's 4 arms, and you take, sometimes if the case only requires you using 3 arms, then you'll just drape 3 of them and put like a mail stand cover over the other one to save money on a robotic drape. The common procedures that I put is robotic prostatectomy, hysterectomy, robotic Whipple, and robotic thoracic. However, I also do a number of robotic hernias. There's places I've been where we do a lot of robotic gallbladders and also appendectomies. Each robotic arm requires its own drape. So the nurse in your room will typically deploy the arms first. They need to hit a couple buttons behind the machine in order for the arms to kind of go down and deploy themselves. And then it'll be your responsibility to then drape the arm. The sooner you drape them, the better, because that's really the main thing that needs to be done before your nurse brings the patient back into the room. So organizing your table, that can wait until after you drape the robot. Drapes must be applied in specific sequence per system manual. So you don't want to do like arm number 3, then arm number 1, and have your sterile drapes in between unsterile arms. It's good to go number 1, number 2, number 3, and then number 4. And it says never guess, follow the vendor sterile technique protocol. And the exam tip, the Da Vinci system has individual arm drapes, camera arm drapes, and instrument arm drapes. Incorrect application contaminate the entire robotic setup. So the camera that we use now does not require a drape. The old school camera might, and depending on where you work, you might have the old school camera. And the instruments go, they're opened up sterilely and they go right onto the sterile drape. So there's no need for an instrument arm drape, whatever that is. Mako robotic surgery drape. This is for total joints, robotic total joints, robotic total knees, robotic total hips, and partial knee replacements. The Mako arm must be draped and registered before the patient is positioned near it. Tracker pins are attached. Post draping, know the sequence, and arm draping requires 2 people circulator assist. So I've actually learned how to put this drape on like pretty well solo, but it's a lot easier when your rep helps you. The rep usually helps you. Next is sterile light handle cover. So when you are doing surgery, you need light so that you can see. And there's a lot of different types of light handle cover. Sometimes the lights have like a handle on it, but the handle is technically not sterile. So you need to put like a sleeve over it, a sterile sleeve, which is a light handle cover so that you can manipulate it and move it during surgery. It's used in all surgical specialties, and it's used in every surgical case with overhead OR lights, applied after sterile gown and gloves are on, and allows surgical tech and surgeon to position lights directly. Common confusion: students forget to apply them before the sterile field is active. That tends to happen sometimes, so I always put them on my Mayo stand. That way we know when we pull in the Mayo stand that that's one of the first things we need to do, either before or after we throw off whatever cords we need, such as suction or Bovie. It's like I do the light handles first or second, and if I don't get to it, then the doctor might get to it, or a PA or an assistant, maybe a resident, whoever. Touching the unsterile light without a cover means contamination. So if you reach your hand up, which has happened to people, happens sometimes, and you forget that the light handle is not up there, just out of like habit, put your hand up, grab it, oh, it's not covered, my hand is unsterile, and then you would need to change your glove. So must be on before you are asked to adjust the light. Exam tip: light handle covers are applied by the scrub tech at the start of every case. Failure to have them ready is one of the most common new tech mistakes. All right, and then also at the end of the case, making sure to take them off. That's an easy mistake too, forgetting it, because you're cleaning up the field and you forget to look up, like, oh yeah, let me get them light handle covers. And our final section, section 3, other sterile barriers, gowns, surgical gowns. Your surgical gown creates a sterile barrier between the surgical team and the patient. Protect the patient from microorganisms on the provider's bodies, and protect the provider from patient's bodily fluids. Reinforced gowns, extra fluid resistant panels at chest and forearms, used in high fluid cases, joint replacements, bowel surgery, OB. And do not use standard gowns when heavy fluid expected. Impervious gowns. An impervious gown is one that's completely fluid proof, used in trauma and transplant. We use impervious gowns for every surgery. Required when blood fluid splash risk is extremely high, and often one size fits all. Plan accordingly for small techs. Next is your Mayo stand cover. You put your Mayo stand cover on your Mayo stand. Your Mayo stand is your workstation. It is where you have everything that you're going to need first, second, and third. You can't have everything that's on your table on the Mayo stand because it's too much stuff, but the Mayo stand is basically, it's in between the sterile field and your back table, and it's like where you keep instruments. Let's say you're busy on the back table, excuse me. And then the sterile field is where the doctor can grab the things that they need without having to ask you. It's used for every surgical case. It's used to create sterile surface for immediate use instruments. It's positioned over and within arm's reach of the sterile field. Common confusion. Student pulls the cover down too far and contaminate the underside. Got to be careful when draping it to not contaminate it. It must be unfolded carefully to avoid touching unsterile frame. Absolutely. And mayo should be set up after back table. Do not rush. So I set up my mayo. It's one of the first things that I set up as I'm setting up my back table. I set up the mayo first because I like to start putting things up there. So I disagree with that point. Exam tip. Mayo stand cover creates a sterile surface directly next to the surgical site. This is where most actively used instruments will live during the case. And when you are past a certain phase in a surgery and you don't need the instruments that were on your mayo stand, you can pull them down and you can put them back on your back table, and then you could pull up the things that you now need for the next phase of the case and put them onto your mayo stand. All right, next, back table cover. So this is used in all specialties, every surgical case. Your back table cover opens sterilely. Usually grab from below the table edge to open it up. That way your hand never touches. You touch the very edges that are going to be under the surface of the table. That way the top of the table will stay sterile. Okay, it's a sterile surface for all of your instruments and supplies, and it's your primary workspace as a surgical tech. Students allow the cover to touch the floor during unfolding. That is a mistake that you want to avoid. Back table must be at the appropriate height before applying cover. And I guess that applies for tables that can adjust, that can go up and down. And cover must extend over all four sides equally. Okay, so you want to make sure it's even. Exam tip. The back table is your command center. The cover must be applied correctly before any sterile supplies are open. A contaminated back table means you are starting over. All right, so draping mistakes that get new surgical techs in trouble. Learn from others' mistakes before you make your own. So reaching over non-sterile areas, leaning over an unsterile surface to place a drape instantly contaminates your gown front. So you do not want to reach over non-sterile areas because you can contaminate yourself. Whenever I'm about to start draping, I don't reach over the patient to give the doctor the drape. I always walk around to the side that they are on and I hand it to them on that side just to make sure I'm maintaining sterility. Touch contamination. Brushing a drape against an unsterile arm, bed frame, or IV pole, even briefly, breaks your sterility, and then you need to throw it out. Dropping drapes too low. Any drape that falls below the table level is contaminated. It cannot be pulled back up because it's already unsterile. Unfolding towards your body. Always unfold drapes away from yourself. Unfolding towards you risks contaminating the sterile surface. These are things that I'm going to be able to show you a lot more when I'm showing demonstrations and videos. Improper sequencing. Draping out of order leaves gaps in the sterile field. Know the sequence before you scrub. So for example, we towel out the area that we are going to do surgery. So let's say we are doing a laparotomy surgery. We will towel out the area, right? Give the doctor all 4 towels. They put them down, they clamp them, or if they're sticky towels, they put them down. Then the next drape that they will take will be a down sheet, which will go over the legs. That way you can more comfortably drape. You're not risking contaminating yourself because you're slowly starting to cover the areas that you're standing in, right? So that's what it means by proper sequencing. And rushing under pressure. Surgeon impatience causes most errors. Slow, deliberate technique is always faster than redraping. Facts. All right, page 30. 5 ways to learn draping faster. Master draping faster than your classmates with these 5 strategies. Number 1, watch every setup, even when you're not scrubbing. Every case is a live classroom, so you can go to other rooms. If you're not scrubbing, it's still a good opportunity for you to watch and observe the draping sequence that will build mental muscle memory, and you will be able to do it when you are on your own. Number 2, volunteer to help set up before every case. Helping your preceptor open drapes, organize the back table, and identify drapes will accelerate your recognition and help you be able to drape better. Number 3, study drape packaging in your supply room. So go to your supply room and look at the drapes that you have in there. It says product labels show drape names, sizes, and intended use. 10 minutes in the supply room is 10 minutes of free education. Number 4, learn the procedure flow, not just the drape. When you understand the full procedure, the steps, then it will help you to understand why each drape is used, why it is important, and that will make it unforgettable. And number 5, ask questions before, not during the case. I mean, it's always a good time to ask questions. It's good to ask questions during the case as well. However, asking questions before the case will build a relationship with your preceptor, and you can ask what drapes are needed the night before or during your morning setup. All right, so that's 5 ways for you to learn your drapes faster. And here in this slide, I want to tell you what we will cover in part 2. We will cover how to open drapes without contaminating them, how to drape without contaminating yourself or the drapes, how to properly unfold large drapes, how to drape a patient step by step, how to drape the C-arm and robotic equipment. And I will show you, a demonstration with a few other people, and common setup variations by specialty. So I will show you how to drape for upper extremity drape, a lower extremity drape, a hip drape, a knee drape, every single possible draping method that there is, I will show you. So like and subscribe to be notified when part 2 drops, because that will be more hands-on rather than a presentation. And all right, our last slide, join the Surgical Guru Academy. So if you want to have CST exam preparation, support while you're in surgical tech school, some confidence when you go into your clinical rotation, or just some guidance as a new grad, OR strategies, travel surgical tech, ortho case mastery, all these things, shorten the learning curve, learn from real OR experience. Subscribe to the Surgical Guru Academy. The link is in the bio. All right. All right, that is Surgical Drapes 101. If you made it to the end of this video, you already have more knowledge going into your next case than most students get in their entire CST programs. That's exactly what we do here at the Academy. The reason I create this type of content is because when I was coming up and trying to learn total knees and gain confidence in the OR, I needed somebody to break it down step by step. I needed a PDF I could study. I needed a mentor who actually cared, and that person initially didn't exist for me. So I became that person for you. And based on the free content I've been putting out, I want to share some of the feedback I've gotten from people in this community, because this means the world to me. Max said, "Just so you know, you are the most selfless surgical tech I know who spent time and effort to help. Max, I appreciate you more than you know, brother." Jenna said, "Thank you so much for this. You are truly an angel for making this." Jenna, that's why I keep going. Comments like yours give me the inspiration. Justin, a Zimmer rep who just started out, said he shadowed 4 total knees and rewatched my video to get faster with the trades. Justin, that's exactly the mentality that's going to make you elite in the OR. Keep grinding, brother. To the OR nurse in Germany who said this content helped you get back up to speed after a long vacation and remember the steps for scrubbing a case. The fact that this is reaching people internationally, that lets me know we're doing something real here. Ansley said the visuals of me putting the pieces together were chef's kiss. She's an OR nurse learning to scrub total knees. Ansley, thank you. There's a lot more where that came from. Hannah, 4 days ago, called me a godsend and said she'll be coming back for all her ortho cases. Hannah, I got you. That's a promise. And to the SPD tech who said my videos are helping him learn the rep trays better. Whether you're a scrub tech, an OR nurse, an SPD tech, a surgical rep, this content is for anyone who wants to be exceptional in the operating room. You belong here too. Now, here's what I need you to understand. All of that, every single one of those comments, that came from free content. Imagine what happens when you're inside the community. Imagine having direct access to me. Imagine being like Anthony.
Joining the academy, telling me exactly what you need help with, and getting a full deep dive video created specifically for you. That's what membership looks like. That's the standard we operate at inside the Surgical Guru Academy. So here's what I need you to do right now. First, smash that like button and share this video with someone in your program who needs it. Second, subscribe. We are just getting started. There's more deep dives, more OR breakdowns, and more of exactly what you just watched coming every week. And lastly, if you're serious about mastering surgical technology, passing your CST exam, crushing your clinical rotation, and eventually building a career that gives you real freedom, click the link in my bio right now and join the Surgical Guru Academy. From student to scrub tech to certified traveling surgical technologist, I built the resource I wish existed when I was coming up. The link is in my bio. Click it, join us. Your future self will thank you. I see you in the next one. Peace.